Well, welcome everyone to today's webinar. My name is Morgan Goldsmith. I'm the Director of Clinical Services for Hospi Corporation with the Macy Catheter and a registered nurse for the Macy Catheter team. We're really looking forward to having you all join us as we present an update on the injectable opioid shortage. I'm joined today by Dr. Nate Hedrick from ProCare HospiceCare. He's currently serving as a manager of clinical services for ProCare HospiceCare, which is a hospice PBM based out of Gainesville, Georgia. Dr. Hedrick's current responsibilities include nurse training and education, hospice costs and utility analysis, and a collaboration with hospice interdisciplinary clinicians. Dr. Hedrick received his PharmD from Ohio Northern and completed extensive training in pain management during his pharmacy residency at Akron General Medical Center. Dr. Hedrick, thank you so much for joining us today.
Of course, thanks for having me.
So before we get started, I'll turn it over to you, Dr. Hedrick. Anything that you'd like to share starting off?
Yeah, I'm just glad everyone could join us today, and I'm glad we got the opportunity to present together today. We noticed, that there's been a growing issue with an opioid shortage, especially from an injectable opioid standpoint, affecting a lot of our hospice clients throughout the country. So we thought, let's get together, just share some opportunities, some techniques for how to combat the opioid shortage, whether that be, just more information about it or what alternatives you can look at in terms of administration techniques or how to convert medications from one to another. All those kind of pieces are what we're going to be talking about today. But ultimately, too, we want to be here to answer your questions. So if you've got specific questions as we get moving forward, like Morgan said, please let us know because we'd love to be able to answer those for you.
Yeah, great. Wonderful. So starting off, I'm sure many of you are familiar with the catheter, with the Macy Catheter that have joined the call today, but I know there's a percentage that the Macy Catheter is new to you. So I thought it might be helpful to just run through a basic overview and background of what the Macy Catheter is. This is Brad Macy, as you can see here. He is a hospice nurse with over 25 years experience. He actually recently retired from working in Kaiser in Northern California as an after hours and weekends nurse. As clinicians, I think we all know that's when symptom management can become very difficult to manage. There's always, whether you're in a hospital, ICU, or home care setting, there's usually some sort of crazy situation that you're tackling. And Brad's story is definitely comes from a situation like that. One night he was taking care of a patient that was in terminal agitation. When he reached the home, the patient was climbing out of bed, was clearly in distress, and the family was just very upset with the patient and how his symptoms were not being managed. So Brad called the physician and he received an order to give a sedative that the patient already had in the home rectally. So Brad administered that sedative tablet and then waited that very difficult wait. And unfortunately, an hour later, the patient was still extremely restless. So Brad knew, again, he had given this patient the medication rectally because the patient was unable to swallow. He called the physician again, talking through, what are the options here? And the physician said, try and give another tablet rectally. So as Brad was preparing that second dose, he realized that the first dose was sitting undissolved in the patient's rectum. And this is when he decided to do something a little bit different. He decided to crush up the medication, add water, and then give it in a suspension form, actually through a urinary catheter that first time into the patient's dry rectum. So once he did that, the patient administered the medication. The patient was resting comfortably in just 30 minutes. And he realized there was probably something here to this method of medication administration. And that was the very beginning of the Macy Catheter. So it came out of a goal to be able to provide the highest level of care in the patient's setting of choice without having any sort of interruption of care once the patient loses the ability to swallow. So as you can see here, it's the 2013 National Award recipient for the Hospice and Palliative Care Nurse of the Year and has since been published in numerous journals, but those specific to hospice, the Journal of Hospice and Palliative Nursing, as well as the Journal of Pain and Symptom Management, which we all have available, plus some more on our website if you're interested.
And just some background on ProCare Hospice Care. Again, I know some of you are coming from different avenues. You arrived at this presentation through different means. So just so you know who we are and where we come from. So my name is Dr. Nate Hedrick, like Morgan has said. I'm the manager of clinical services here at ProCare Hospice Care. And we're a national PBM based out of Gainesville, Georgia, which is just north of Atlanta. But we serve hospices all over the country. And we really pride ourselves on really three things. And I think it shows why we're doing presentations like this and why we work with corporations like Hospi, because it's so important to us. And the first is being patient-centered. We want to be as patient-centered as possible. Every decision we make is always from the patient's perspective and the patient's point of view. So broad formulary decisions are helpful in terms of guidance, but ultimately you've got to make decisions at the patient level to basically take care of them as best you can and also manage your costs. As part of that, we also want to be hospice specific. We're not a cookie cutter model. We're not a one size fits all. We're big enough to have the buying power that we need to be a national company, but small enough to be flexible. And that's really important to us to maintain that flexibility that we have. And then finally, we want to be the most nurse-friendly PBM that you've ever worked with. Our goals are ultimately to work with you guys day in and day out. And if your nurses aren't happy, then nobody's happy. So our whole goal is to be as nurse-friendly as possible. So again, just some background on who we are and what we care about and why we do presentations like this for you guys, again, to kind of further these goals. All right, so jumping right in, getting into the clinical. What we're talking about today is the injectable opioid shortage, and I want to start by assessing the problem. So what is the problem? If you haven't already experienced it, what is the problem? And really what we're seeing is that right now, morphine, fentanyl, hydromorphone, and I don't have it on here, but in very select markets, methadone in its injectable form is on back order or is very difficult to get or is inconsistent to get from suppliers. And generally it's very limited. And we're seeing this we asked the question when you guys signed up, are you currently experiencing an issue? And it was a total gambit of no, absolutely no issue at all, to people that are like, yes, for months it's been a problem. So it definitely depends on your area and your suppliers, but we're seeing it kind of widespread at this point. And I'm guessing that many of you are here because you're either worried about it coming up or you're already experiencing the issue. One of the other things that we're going to talk about today is just alternative routes and alternative ways to kind of get around injectable opioids if there is a shortage. But if you're not currently experiencing a shortage, but you are kind of thinking about the general limitations of the IV route, I want to go over those as well. And the biggest one really is cost. While it might be convenient for giving patients an IV and the titration is nice and quick, from a cost standpoint, it's usually quite expensive. So even if you are able to obtain the drug, it's usually at a premium and it may not be the best option for you. It also ups your level of care required. Not as many patients at home can be receiving IV care. If it is, it's got to be like a CAD pump, especially for opioids, something that isn't as modifiable by the patient and their family. If you're at a facility, sometimes it can increase your level of care from one level to the next, which might increase the cost for the patient and their family. So there are a number of concerns there. And then finally, the complications associated with it, injection site reactions or IV line placement reactions, complications from, combining drugs as you're entering, giving them all parenterally at the same time. There are a number of things that we worry about long-term as well with continued IV placement. So even if you're not experiencing the opioid shortage yet, and you're looking at ways to get away from IV drugs because of those limitations, we're going to be able to help you as well and kind of go through some of those options. Many of you asked why this shortage is happening or why shortages occur in general. And there are a number of reasons. In fact, if you look at the FDA website, these are kind of the top 6 reasons that they'll give for delays. Manufacturing practice concerns, it sounds ridiculous, but basically the FDA is always updating what is appropriate in terms of manufacturing processes. So what is considered safe, what is considered consistent, what's a standard of error that you're allowed to kind of play into. And as they update those processes and those requirements, then manufacturers have to go through updates themselves. They have to actually build better facilities, updated equipment, all that stuff. And in fact, one of the issues we're seeing right now with Dilaudid is completely and totally due to one of these manufacturer upgrades. The FDA came in and basically said, okay, I believe it was Purdue or I'm not sure the pharmaceutical company, but said, okay, you need to update your manufacturing processes. So go ahead and do that. And they've had delays in construction. And because of that, they're not able to develop as much of their drug in time. And that itself is leading directly to a shortage. So that's one. Regulatory delays, not usually a concern for active and available drugs. You know, if you have something that is new to the market and it's not meeting regulations right away, that would be a regulatory delay. So not something that we're going to experience too often, especially in hospice. Sometimes you can have a shortage of the active or inactive raw ingredient. This could either be the drug itself. This could be one of the agents that go with it. This could be the plastic that they put in the IV, or that they use to make the IV bag, actually. We actually saw a lot of issues with this with Puerto Rico when they underwent the hurricane. A lot of IV drugs and a lot of basically IV bags were being made in Puerto Rico, and all of a sudden we had a shortage of basically the raw ingredients from them, and weren't able to produce the drugs. So that comes up as well. Occasionally there's discontinuation of the manufacture of the drug. Obviously that would cause a shortage, because now even if one of those suppliers, if there are multiple suppliers, if one of them stops, you know, as a result, there's not going to be as much drug to go around, and maybe there'll be manufacturing delays and product delays as a result. There could also be delays in shipping. Again, that usually shouldn't be quite as big of an issue. The delays are usually minimal and usually only the short course. And then finally, there's kind of this last one, and that's the demand increase for the drug. And regardless of what opioid you look at, actually, this is one of the issues listed for every single one of them on the FDA website. There is simply a demand increase for every opioid available. And we can talk for a whole separate presentation about the implications of that and kind of what that means for the industry. But basically, more people are using opioids in whatever capacity that entails. And because of that, less is available. And that's simply what we're dealing with right now. So it can be a multitude of factors. We want to talk about how to find an alternative, okay? So what are we going to do in order to find an alternative now that we know maybe we don't want to use an injectable drug, or maybe there is a shortage on the one that we've been using? The best things you can do up front before you're talking about making a switch is really kind of walk through a stepwise approach about how we're going to make these changes. So the very first thing is determine their current regimen and their requirements. I know that sounds silly, but we often get phone calls and they say, I need to switch this patient from drug X to something else. And the person calling isn't even totally aware of what drug they're on or how much they're using. So make sure you know their routine dosing. If they're on like a CAD pump, exactly how many milligrams of drug they're getting in a 24-hour period, and their CAD pumps will tell you. And then also their breakthrough utilization, how much they're using in the last 24 hours. We're going to go through a case at the end, and I'll show you how that number can be a big difference in terms of how much it's giving and how much it can affect the overall conversion rates. So that's really important, the routine dosing and the breakthrough utilization that the patient's currently using. Always review the patient's history and allergies. Maybe there's a reason they're on an IV drug. Perhaps they can't take pills by mouth. Perhaps they are allergic to some of the agents that we would consider using. Perhaps their medical history doesn't allow that drug based on interactions or based on concerns for their heart or for whatever. So always looking at their history, fully assessing that history and those allergies before deciding what drugs we can potentially switch to. And then finally, what we're going to really get into today, assuming you're doing all that, is assess the available routes for that patient and talk about, let's look at what routes are viable options for this particular patient. And so we'll get into that now. So the first alternative, and the one that I think we kind of turn to most often perhaps in hospice, is sublingual. And I think the reason for that is because it feels like it's the same as PO, right? The patient was taking it by mouth. Well, now they can't, so we'll just dissolve it under their tongue. So what does sublingual actually mean? And this is a really good kind of diagram here that kind of highlights exactly where this absorption is going on. So under the tongue, we have these huge sublingual glands, and they're directly connected to our bloodstream. And so once you place the medication under the tongue, if the medication dissolves, and we'll talk about what that means in a second, but if it's able to dissolve and able to diffuse through those membranes into those glands, the medication can get directly into the bloodstream very rapidly without first pass metabolism in the liver. And that does a lot of things for us. So advantages, it's not invasive, it's family friendly, right? I can easily, if I'm giving the patient pills by mouth, I can easily give them pills under the tongue, hopefully. More important, rapid absorption and activity. Think about nitroglycerin tablets. Anybody who's ever given or seen or learned about giving a nitroglycerin tablet knows that you give it under the tongue and knows that it acts immediately. And that's by design because it doesn't have to go through first pass metabolism. It's not going into the stomach where it has to get absorbed and then pushed into the bloodstream. It's diffusing into the membranes and getting right into the bloodstream right away and going right to the heart. So nitro is a good one to think about when you're thinking about sublingual administration. The disadvantages here are primarily that you have a limited volume. You're dealing with under the tongue. There isn't a lot of space there. So you have really limited volume and really limited access to what you're allowed to give. So really beyond 10 mLs, and that's probably been pushing it, is really not going to happen. So if you've got a drug that's not well concentrated, if you've got a patient that has a very dry mouth to begin with, and you've got to add liquid to it to get that drug to help to kind of dissolve, any of those things basically limit your options in terms of delivering it sublingually. The other option is that it really favors lipophilic drugs. And I'll show you the scale here in a second. In fact, here we go. It favors lipophilic drugs, so the top of the chart. So the more lipophilic, the more fat-loving you are as a drug, the more likely you are to diffuse through that membrane and into the salivary gland that we need you to go to. The more hydrophilic, the more water-loving you are, the less likely you are. That's not to say that these drugs will not absorb sublingually. They're just less likely to be as effective. So we're quick to move to morphine and use morphine sublingually, but you'll see it's pretty low down on this list. I'll tell you, it will dissolve. Morphine will dissolve sublingually. It will work, but it's certainly not as effective as some of alternative options. If you look at some of the products that are available on the market, one of the ones that we don't use a ton in hospice primarily due to cost, but you see a lot in oncology patients is fentanyl, transmucosal fentanyl citrate. And transmucosal fentanyl citrate is a film or a spray that can be given sublingually, and it dissolves super rapidly, and the onset of action is within seconds. It's really, really great drug for sublingual administration because it's lipophilic, because it's actually given in kind of like a liquid form or a dissolvable form. It's able to get into the bloodstream very, very quickly. The issue, obviously, with that one is cost, so we don't use it as much. But this kind of shows you, if you're looking at that spectrum, you know, it's going to be much more difficult to dissolve, especially large volumes of some of the drugs like morphine, hydrocodone, codeine, things like that. A little bit easier to get methadone, fentanyl, buprenorphine into the patient. All right, we'll move on to another option, which is transdermal administration. And many people like transdermal administration because it's not very invasive, right? We just slap a patch on the patient and they're good to go. Unfortunately, there's some limitations, and we'll go into that. But primarily what transdermal administration is medication that's applied either in a patch or a film of some kind, or even a semi-solid. Think about your topical analgesics that are basically rubbed into or applied to the skin directly. That medication, through various mechanisms, basically dissolves into the skin. Sometimes it will go into the fat and create what we call depots, basically little fat stores that release the drug. And sometimes it goes directly into the blood system. But either way, it's going to dissolve through the skin and eventually get right into the bloodstream. Again, because of that, it's going to bypass first pass metabolism in the liver. So you can get drugs directly there without worrying about the gut kind of chewing them up. But it's pretty slow. A lot of these drugs take time to diffuse through those membranes. A lot of them take time to get through the layers of skin and to the bloodstream. Again, some of them have to create a fat depot, like fentanyl. Fentanyl actually hides in the fat, creates a depot there, and then the drug releases. And because of that, it can take up to 18 to 24 hours for some of those drugs to kick in. So it's a pretty slow process, but still it has its advantages. Primary among those, it's non-invasive, right? It's very family friendly. The patient doesn't even have to move. They don't even have to be awake to get a transdermal patch applied. So very, very simple. So a lot of people like it for that reason. It also limits your GI irritation. There's no drug being given orally. There's nothing the patient has to worry about nausea because of. So a lot of times people like transdermal administration because there is no gut that I can upset. There's no drug that I can have emesis and lose. It just simply gets absorbed no matter what. Now with that though, there are some trade-offs, and I talked about the slow absorption and the difficult titration, right? The drug doesn't kick in for a while, but this also requires lipophilic and low molecular weight drugs. In hospice for years, we've been inclined to just try to give every drug transdermally because, again, the C advantages, right? We've tried to give every drug transdermally, but ultimately a lot of them do not get absorbed. One of the examples that I've done some research on and that our hospice team has done a lot of research on is ABHR gel. And a lot of the components in ABHR gel are simply too big. Their molecular weight is simply too high to dissolve effectively and get into the bloodstream. They did a test with standard concentration ABHR gel in healthy volunteers. They applied it to the skin, measured blood levels. They measured blood levels, then applied it to the skin, waited 15 seconds, waited 5 minutes, waited an hour, measured blood levels at each of those intervals, and found almost no drug was being absorbed to the skin simply because it was too slow. They even waited a day. Then they said, maybe it's just not getting in there yet. They waited even longer. The drug never reached concentrations that were considered efficient to be effective. So we've used ABHR gel for years, but a lot of times we may be treating ourselves or treating the family instead of the patient because that drug simply isn't small enough and not lipophilic enough to get into the system that way. So big limitation of transdermal administration is that we're limited into what can actually absorb through the skin. And quite honestly, a lot of that is by design, right? The skin has been designed to stop things from getting into the body. It's a protector for us. So it's hard to get things past it. I'll jump now to rectal administration. So definitely another option. And rectal administration is exactly what it sounds, right? We're inserting drugs directly into the rectum. They're being absorbed by the blood vessels there. It's very similar to PO in that route in that it's basically being administered, it's dissolving, and then it's being absorbed. The difference here is that it's bypassing that first pass metabolism again. There's no gut that has to deal with it. It's just simply dissolving into the membranes and then into the bloodstream. The advantages, obviously, because of that, just like sublingual administration, are the rapid absorption and activity. We can get really quick activity as long as the drug is able to dissolve, and it gets right into the bloodstream, and we have no problems. Again, no first pass metabolism, which is great, especially for those lower concentration drugs. And liquid medications are absorbed more quickly than suppositories. We know this to be true simply by the mechanism of action. All of them will dissolve at some point. It's just a matter of how quickly. And like Morgan's story kind of highlighted, if you've got a dry rectum or if you've got a patient that maybe has a slow dissolution rate, a suppository might not work at all. Ultimately, the medications will absorb, but they have to kind of be absorbable first. So that's important. The disadvantages, what we really see is that it's not very family friendly. Many of you nurses, I'm sure, have tried to talk to a family member about giving a suppository, and they're just like, nope, it's not happening. So very difficult sometimes to get the family on board. And then repositioning, you know, if you're constantly administering a suppository for these patients, if you're flipping them over to give one, if you're undressing them to give one, all that kind of stuff, that can be discomforting in terms of physical. It's discomforting to the patient to roll them around on the bed or whatever they need, but also emotionally too. It just may be degrading for them, or they may just not feel comfortable with it, especially with their family members there. So repositioning may just cause the patient additional discomfort as well. So some of the ways that Hospi has kind of been working to get around that is pretty unique. And I'll turn this over to Morgan here so she can kind of walk through some of the ways that the Macy Catheter helps to belay some of those disadvantages that we're talking about.
Wonderful, thanks, Nate. So as you can see here, you know, the Macy Catheter, I mentioned it before, but this was developed by Brad, who's a hospice nurse who really wanted to be able to enable patients to remain in the setting of their choice. So it is approved for the administration of medications and fluids, easily placed by the nurse when the oral and sublingual route fail. So again, the majority of our patients, they're not going to have issues with symptom management at end of life when they start to lose the ability to swallow. But for those that do, the Macy Catheter is a great option. To speak to the last 2 points that Dr. Hedrick mentioned with regard to repositioning patients, and that, you know, suppositories aren't something that's always family friendly or preferred way to give medication. As you can see here, the Macy Catheter is a great solution for that. So the catheter, once placed, is simply secured to the patient's leg, as you can see here in the image, or it can be attached to the patient's lower abdomen. So that means that the clinician or the caregiver only has to access that port to be able to give medications. I'll get into some of the specs of the catheter itself in a moment, but just to reinforce again, you know, this is a solution and a product that enables you to give medications that are already at the bedside. It is discreet, it's super comfortable for the patient and very easy to use. Usually the feedback that we receive the first time that clinicians will place the catheter, it might take about 5 minutes or so. It is a non-sterile procedure because the catheter is being inserted into the rectum. But once nurses are able to insert the catheter for the first time, it's usually 3 minutes or less for our regular utilizers of the Macy catheter. It is approved to stay in place for up to 28 days, which is great. So it can stay in place for ongoing delivery. The next question that we always get asked is, what happens if the catheter is expelled? Well, it's actually designed to be expelled with a bowel movement. So if a patient were to be having a bowel movement, or if they felt like they had to, the nurse or the caregiver could simply deflate the balloon, or the balloon would actually be expelled with the bowel movement. The catheter could be wiped off and then reinserted, again, because this is a non-sterile procedure. To Nate's point as well, there's no turning or bothering patients. Again, this isn't something where you have to reposition every time that you're giving a suppository. And end-of-life medications are quickly absorbed rectally, and Dr. Hedrick will get into that in a moment as well and share some more specifics. So this is a close-up of the Macy catheter itself. I know my image on the screen is pretty small, but I actually have a catheter here so you can see kind of how small it is compared to my hand. A good Macy joke, this is actually a clean catheter, I promise, so I'm holding up here today. But real quick to just go through the components of the catheter. First, you have the medication administration port, and this is where all of the medications that are crushed when water is added, so it's in a liquefied suspension, are injected using an oral or intraoral syringe, and that's what this connector is, and you can see it's marked with meds. The next is the balloon inflation port. You simply connect a bore syringe to the balloon inflation port and inject that with 15 mL of room temperature tap water to inflate the balloon. Next, you have 3 placement marker lines here. There's 2 arrows with a straight line in the middle. Once the catheter is placed in the distal third of the rectum, that straight line will sit just outside the patient's body, and that's how you know that it is placed in the distal third of the rectum. And then again, you've got your balloon, which is inflated to 15 mL, just using room temperature tap water. And then 4 medication delivery holes. Here you'll see 2 holes here, and then there's 2 holes on the opposite side. The catheter itself is 14 French, 20 inches in length. It does just come in one size, and it's made of all silicone, so there are no latex components to the catheter. Great, and the next questions that we receive quite a bit, okay, here's catheter, here's a solution for giving medication rectally. How easy is it to place? And this is it, guys. It's 4 easy steps. You first lubricate the distal end of the catheter tip to that first blue line. You insert the catheter to the line between the 2 arrows, so it sits just outside the patient's body. You inflate the balloon with 15 mL of room temperature tap water, and then you simply secure the device to the patient's leg or lower abdomen, or excuse me, the medication port for easy access for the caregivers or clinicians. We recommend that clinicians are the first to insert the catheter, but depending on the agency's protocol, we have many agencies that then teach the actual caregiver how to insert the catheter if it were to be expelled, and of course, how to give medications through the catheter itself.
Great, thank you, Morgan. And like I said, that's a really good look at just how we're able to get around some of the issues that we deal with rectal administration as one of our options. So just a quick comparison here. I wanted to show some of the other drug classes. I know we're really talking about opioids today, which is the top of this chart, but just so you have some perspective as to what can be given rectally and via different routes. This is a nice full chart that kind of looks at all those drugs. Obviously, opioids kind of across the board, we have options. As we get into some of our other medications, we do get a little bit more limited. What's nice is, though, that all these medications listed here, all these medication classes, within reason, are able to be given rectally. So it ends up being a really nice route, because if the patient does lose the ability to give medications orally, it's usually a pretty quick conversion to kind of get them switched over to a rectal administration of that drug. Whereas if we wanted to go IV on some of these, while we do have options, we don't have options for everything. And sublingually, even less, transdermally, even less than that. So it's just a nice option in terms of versatility. And this is a good comparison that shows the medications across the board on that. All right, I want to kind of wrap this up here and then, of course, offer a chance to go through some questions with a case to kind of show how this might work. I mentioned earlier when we were talking about how to ensure your patients on the right drug and converting them over. And so this is what we do a lot at ProCare is assist our patients and our nurses with converting patients that are on one medication to another. Often this will be IV and getting them onto a rectal drug. It'll be IV getting over to methadone, things like that. But this is just one example of how this might look. So we've got Mr. Smith here. He's a 62-year-old male. He says with esophageal cancer, significant Mets. Because of the esophageal cancer, cannot any longer swallow pills. And he's in the hospital, but he's going to be discharged home here soon. So in the hospital, he was using morphine IV, 2 milligrams Q4 hours routine. It was just an implanted port that was being done. And IV 1 milligram morphine 1 milligram IV Q1 hour PRN. He's been pretty well controlled in the hospital using about 7 or 8 doses of breakthrough per day. But let's just say now he needs to go home. We can't give medications IV in the home, or maybe he's going to a nursing facility that won't allow that. There are many reasons. But let's say for whatever reason, he can no longer take medication IV. Or perhaps we're running out of the drug because there's a shortage, right? So whatever reason, he can't be taking IV any longer. So now we've got to switch them over to rectal administration. So how would we actually go through and do that? What you need first to understand is the basic conversion chart between opioids. And this is just a small look at some of the drugs that we convert. It's obviously not all inclusive, but it has the medications that we're concerned about here today. Basically for morphine in this case, when you're looking at converting morphine from IV to sub-Q to rectal or oral route, it's about 3 times as potent in the IV formulation. So you have to kind of know that going in. Okay, I can't just one-to-one convert. IV is 3 times as potent as oral. If I were converting from a different medication to morphine, let's say, or a different medication to like morphine to hydromorphone, I would have to then convert basically from those to another. So for example, hydromorphone is 5 times more potent IV than it is PO. So if I had a patient that I wanted to convert from hydromorphone all the way over to morphine, let's say, I'd have to basically do the math to get them from hydromorphone IV over to the morphine route that I was going to be using. So in this example, I would multiply the hydromorphone IV dose by 5, get over to the oral or rectal route of hydromorphone, and then again, multiply that by 4 to get to the morphine route. So I'll show you it in actual math here in a second, but basically you can convert any opioid to another if you have a chart like this. All right, so we said he has IV morphine at 2 milligrams an hour, 2 milligrams Q4 hours routine. So that's IV, right? 2 milligrams IV times 3, because it's 3 times as potent. So we get 6 milligrams of PO or rectal morphine, which again, if we're looking at Q4 hours routine, is about 36 milligrams in a day. Then we've got his breakthrough med. So he's got morphine at 1 milligram Q1 hour, using about 7 or 8 doses a day. So let's just say it's 7. Well, it looks like I actually did both here. So maybe the 1 milligram times 3 equals 3 milligrams per dose if you're giving it PO or rectally, or about 21 to 24 milligrams per day. What that basically gets us to is that the total oral morphine equivalence is about 60 milligrams per day. That's what he's using orally as an equivalent dosing. We did all the math. 36 plus 24 is about 60. Well, it is 60, but he's using about 60 oral morphine equivalents in a given day. And that's a really good guideline to say, okay, what are they actually using? Now, let me design a regimen based on this information. Because if I just stopped at the routine dose and the breakthrough dose and just continued everything the way that it was, I would probably take care of his pain. But how do you give 6 milligrams and 3 milligrams of morphine consistently? You know, those little dropper bottles, you're trying to, parse it out exactly right. The tablets come in 5s and 10s, so that's not going to work. So it's always best to kind of get your total oral morphine equivalents and then develop a strategy based on that information. So I get 60. I'm going to go ahead and try to divide that out here as best I can, knowing that 60 is kind of my limit. That's my upper limit of where we're at. So if I design a new pain regimen for this patient, what I'd probably be looking at is 7.5 milligrams of morphine liquid, and that's 20 per 1. I'd like using the liquid in this case because I'm going to be doing it rectally via the Macy catheter. So I'm going to do 7.5 milligrams Q4 hours routine to kind of give him his routine dose. Obviously, that's a little more than the 6 milligrams he was getting, but hopefully we can use a little bit less breakthrough medication because he's already getting 7 to 8 doses a day. And then obviously I want to make sure that he is getting those breakthrough meds. So I'm going to use about 5 milligrams, again, a little bit more than what he was getting. Hopefully he's going to be using a little bit less now that we've got a bigger routine dose. Q2 hours breakthrough pain. And that's just one example of how you can take all that math and boil it down into actually converting the patient over. And we can do this with any medication in any concentration. It obviously can get a little bit more difficult if we get to very, very high doses. And that's where we start talking about using more methadone. But in this example, the doses are quite low enough with morphine that we can easily convert them over to rectal, even consider sublingual administration in this particular patient because the doses are low enough as an alternative option. All right, so hopefully that sheds some light on kind of how we might go about doing that dosing. Hopefully this has been a little bit more eye-opening in terms of some ways to get around the current opioid shortage that we're facing, and some alternatives for injectables in general.
Yeah, thank you so much. And if anyone has questions or if you've got to jump off the webinar, please feel free to visit either of our websites. There's a massive amount of resources, lots of different publications and training tools available. And if you have any specific questions, feel free to contact us at any time. We'd be happy to connect and answer any questions that you have. In light of the shortage, we've had many agencies reach out and from the Macy Catheter perspective, learn quite a bit about how we can help in light of the shortage. And it's been a great benefit, especially to those that have large IPUs. So please let us know if you have any questions. And again, we will have this available on both of our websites for easy reference, and so you can share with your staff as early as next week. Well, thank you so much, everyone, for your time. We sincerely appreciate taking time out of your day to join us, and please do not hesitate to reach out if you have any questions. Dr. Hedrick, thank you so much. It was wonderful to be able to partner together, and I hope to do it again.
Yeah, of course. Thank you.